involuntary. For example, you cannot make your heart rate to go up. Yeah, because this is part of the autonomic nervous system. Just does it without your conscious control. So you don't know what is. There's no your consciousness is not part of what is happening when you're using the autonomic nervous system. The autonomic nervous system is divided into two main components. We have the sympathetic, and then we have the parasympathetic. The sympathetic happens to always have opposing reaction to what the parasympathetic does. So if the sympathetic, for example, increases the heart rate, the parasympathetic will do the opposite. It will decrease the heart rate. Now, you might have had the sympathetic being called the flight or the fight mode. Okay. I think it's the one that predominates in situations of flight. Okay, I just had an incident of flight whereby I was attacked by a thief. That's why you saw me delay. But what was predominating me at that point was the sympathetic nervous system. Or, for example, if you're walking on the street and you meet an unfriendly dog and you decide to run away, or maybe hear gunshots, that's what the sympathetic does. So the best way to think about it is if you're asking yourself, every single system that is involved with a sympathetic, you ask yourself, what will happen to this system when I'm in the fight mode? Then the parasympathetic is predominantly known as the rest and the digest system. So it's the one that predominates during times of rest and digesting. Okay, it's the one that makes you actually sleepy because it's the one that predominates during the rest and digest, as we're going to discover. Now, the best way to think about the sympathetic is by every system, what it does to every system. If we begin with the CNS, the sympathetic is known to cause constriction, and then the parasympathetic is known to cause dilatation, pupillary dilatation. Now, sometimes you may not, like for example, when they are testing, you may not see pupillary constriction. Pupillary constriction, they may use a word called meiosis. Meiosis is the same as pupil constriction. Okay, and then of course, sorry, I beg your pardon. The sympathetic causes mydriasis, which is vasodilatation, and then the parasympathetic causes meiosis, which is vasoconstriction. I just interchanged them. Okay, and you think about it, when you are running away from something, you want your eyes to be open more. So that's how I think about it. You want your eyes to be open more, so you want them to be dilated. Okay, so that was just a mistake. Then and when you consider the CVS, for example, the heart rate, okay, what will happen to the heart rate when you're in flight mode? You expect the heart rate to increase, to be higher. And then when you're resting, then you expect that the heart rate will decrease, okay? That is in the parasympathetic. Then when you consider, so it is easier to think about it. But one of the things that confuses people is when we talk about the urinary system, okay? So the urinary system in times of sympathetic stimulation, okay? It causes urinary retention, okay? Because if you're running away, you cannot want to go and pass urine. It's something that confuses people very many times. But you need to, sympathetic causes urinary retention, and then parasympathetic causes you to pass urine, okay? Another way to think about it is that the parasympathetic makes you leaky, can cause you to pass stool, it can cause you to pass urine. So that's another way you can phrase it in your mind so that you do not forget it. Okay. Now, another thing to know about the sympathetic and the parasympathetic is the neurotransmitters that are produced on the different ganglions. Okay. The best way to think about it is that acetylcholine is the predominant neurotransmitter that is released in most of these nervous systems. Sorry, most of these nerve endings. So as you can see from here, from this diagram, the parasympathetic has long preganglionics and short postganglionics, and it has its source from the cranial nerves and also the caudal. So it has craniocaudal. That's where the parasympathetic comes from. The sympathetic is thoracolumbar region. That's where it comes from. Okay. So when you're going to be talking about, for example, spinal anesthesia, or maybe in the later chapter, so the spinal is usually done in the spine, and it's done about L4, L5 in an adult. So, and then you block, sometimes you block up to T4, T5. So yeah, in this case, you're blocking, but you're predominantly blocking the sympathetic system. So since you're predominantly blocking the sympathetic system, then you're not affecting the parasympathetic. And then the sympathetic will predominate. So since the sympathetic is blocked, it is not working. That means because the sympathetic is in charge of vasoconstriction, then that means you'll have vaso dilatation. Okay. And that's the reason why you'll get hypotension, as you'll see when you start doing spinal anesthesia. I don't know when you're going to do your rotation, but when you do your rotation, you'll see this. So as I was saying about the neurotransmitters, okay, the most important neurotransmitter that you have to know is acetylcholine. Acetylcholine is both on the preganglionic sympathetic and preganglionic parasympathetic. And also in the postganglionic sympathetic, acetylcholine is the neurotransmitter that is released. Then in the sympathetic, then we have a norepinephrine. That norepinephrine is the one that is predominantly released. So that is the only difference, okay? So the thing to summarize about the neurotransmitter, the neurotransmitter that is common in the autonomic nervous system is acetylcholine, with the exception of the postganglionic of the sympathetic system, okay? And then also there's another exception, the adrenal medulla has only the preganglionic. So the neurotransmitter that is released is acetylcholine as expected, but since it doesn't have postganglionic, then it's only the acetylcholine that is present. Okay, but remember the adrenal medulla produces norepinephrine and epinephrine. Norepinephrine is still, it produces norepinephrine and then also epinephrine, and it's the only organ that produces the epinephrine, or what we call the adrenaline. It's the only organ. So the adrenal medulla has acetylcholine as a neurotransmitter that stimulates the adrenal medulla because it has only the preganglionic. It doesn't have postganglionic like the other sympathetic systems, which have norepinephrine that it is released on the postganglionic receptor. So that means that if they ever ask, they may ask you a question about the neurotransmitter that is produced by adrenal medulla. Okay, adrenal medulla produces norepinephrine and epinephrine, but the neurotransmitter that is there at the preganglionic is acetylcholine. Okay, and this one sometimes is very confusing because there are 3 neurons involved. Okay, in the preganglionic neuron, The neurotransmitter that is produced is acetylcholine, which stimulates the adrenal medulla to produce norepinephrine, and with the help of cortisol, norepinephrine is converted to epinephrine. So in other words, it produces norepinephrine and epinephrine. Okay. So I've already talked about this. Acetylcholine is a very important neurotransmitter. Now, this is the postganglionic, okay? The preganglionic, we say the parasympathetic postganglionic produces acetylcholine. Notice that the receptors that are there are nicotinic receptors. So the nicotinic receptors are on the preganglionic. And then on the parasympathetic, on the postganglionic, they are muscarinic receptors. Then just moving to the sympathetic, the sympathetic preganglionic, it has nicotinic receptors, and the postganglionic has adrenergic receptors. So what does that mean? Receptors and postganglionic. If it's parasympathetic, they are muscarinic receptors. If it's sympathetic, postganglionic, it is adrenergic receptors. Now, this is very important because when we talk about autonomic nervous system, we're going to talk about acetylcholine. When we talk about the drugs and the production of acetylcholine, and also at some point we shall talk about norepinephrine. Now, when you talk about muscle relaxants work on nicotinic receptors, but autonomic nervous system drugs, we're going to be talking about their effect on postganglionic receptors. But when you reach the chapter, when you talk about muscle relaxants, we'll talk about saxamethonium, atracurium, all those drugs that you've seen being used in theater. Those ones are working on nicotinic receptors, they are working on nicotinic receptors preganglionic. Okay, these ones, autonomic nervous system drugs, are working on postganglionic receptors. Okay, so I've already talked about adrenal gland being the only exception. This is just a summary of basically what we've already talked about. Padre, do you have a question?
No.
So now, basically, I want to talk about how drugs, we're going to talk about drugs. So that's all I think you need to know about the physiology of autonomic nervous system. There are more details that, but I think this is the only, the main point that you need to get. That's the bigger picture that you need to know. Now, so we already talked about two neurotransmitters, acetylcholine and norepinephrine, okay? So those are the two main neurotransmitters that we're going to talk about. Now, and we are talking about postganglionic receptors. So as you know from your pharmacology, neurotransmitters that are drugs that mimic neurotransmitters, they are receptor agonists. And these ones are the ones that activate receptors. And the ones that inhibit are called antagonists. Now, we classify them according to, we're going to talk about the parasympathetic nervous system drugs, and then we talk about the sympathetic system. Drugs that mimic acetylcholine, you'll see us referring to them as muscarinic agonists. Sometimes they're called cholinergics. We're not going to talk more. These drugs are not, that group, we're not going to talk about it in this lecture a lot because I think you'll not come across it a lot in anesthesia. Then the ones that block acetylcholine will be anticholinergics or muscarinic antagonists. And these ones are usually tested a lot, especially in anesthesia. I can say that at least you'll get 1 or 2 questions talking about muscarinic antagonists in your exam. At least there could even be more. So you should know this one. Well, I'm going to tell you what you need, or the only thing that you need to know about muscarinic antagonists to pass any exam, any question they can ask you on this. Then sympathetic nervous system, we have the ones that mimic norepinephrine, which are adrenergic you hear us talking about them as sympathomimetics, and the ones that block norepinephrine, you hear us talking about them as sympatholytics, okay? Or adrenergic agonists or antagonists, because they're working on adrenergic receptors, okay? So I think we're going to begin with talking about the sympathetic nervous system drugs. This is just a summary of what is what effect the sympathetic response for every drug or response. The pupils are dilated, and then in parasympathetic there's constriction of pupils. In the lungs, we didn't talk about the lungs, but they dilate bronchioles, okay, because you want more oxygen in so that you can run away from whatever is threatening you at that moment when you're in the flight and fight response, or the sympathetic, when you're in the sympathetic response, okay? Of course, the parasympathetic does the opposite. It constricts bronchioles and increases secretions. Remember, I told you the parasympathetic, you can also think about it as the leaky mode, where you're leaking things, leaking secretions, leaking, maybe can cause diarrhea, leaking urine. So it's a leaky state. So you're leaking from everywhere. Of course, I talk about the heart, the effect, the sympathetic response with the heart causes increase in heart rate and decrease in heart rate for parasympathetic, okay? So it increases heart rate and constricts blood vessels, the sympathetic response. And then you have an opposite response for parasympathetic. So the bladder, it relaxes bladder muscle. Sympathetic relaxes bladder muscle. So when you relax bladder muscle, you constrict the sphincter, so urine cannot pass, okay? When you constrict the bladder, because when you squeeze the bladder, then urine comes out. So the parasympathetic is the leaky state, okay? And then of course the salivary gland, it increases salivation. So in summary, I would say, if you think about the sympathetic response, think about it as the flight and fight mode. And then the parasympathetic, you can think about it as the rest and digest. But I would also add on that it is the leaky phase, where you're leaking from everywhere. Increased salivation, increased secretions, increasing bowel movements like diarrhea. Then you can also think about it as increasing urine passing out, okay? Someone raised their hand.
Yes, doctor.
Yes,
The question.
Yes. Yeah. Alan, you've asked a very good question, because actually I think this has been one of the this is one of the questions that have been asked a lot when I talk about the sympathetic response concerning the bladder, okay? If you're having the sympathetic response, this is what we expect with the normal physiology: relaxation of the bladder muscle, constriction of the sphincter, so urine cannot pass. However, I have also noted it that people actually pass urine when they are in the flight mode, but I've never seen someone who has been attacked by maybe let's say dog, or maybe he has gunshots and decides to go and pass urine. I think it's but when you're sleeping and you're having a dream, yes, I think it can happen. Well, it could anything. I don't know. I don't know how to answer that, but I've been asked many questions about that. Yeah, I've been asked many questions about that. I'm not sure, but it happens. But the normal response should be a sympathetic response. Okay. But however, I have to say, when you check in neurology, actually coming to think about it, some of the things that make you pass, I think there's also a kind of parasympathetic response. I guess because maybe there's a caudal As you remember, the parasympathetic, we said it has its source from the caudal. We have the cranial and caudal response. I guess maybe because the parasympathetic also has its source from, it has caudal roots. But I cannot say that's a definite answer. There must be another reason why. But the normal response should be to relax the bladder muscles and constrict and constrict your constrict your urethra sphincter. And the eventual, because the people who decided to urinate when animals were running after them, they were eaten by the animals, so they never lived to become your ancestors. They were eaten up. So I think that's the normal response.
Okay, excuse me.
Yes.
I've seen in such instances
Yes.
that you usually lose the decision between either to fight or to flight, and you're just paralyzed in the situation.
Yeah.
So that kind of relaxation that comes in, could it be the one activating the parasympathetic until you urinate?
I think so. Well, I don't know why, because even in those states, the sympathetic response, you expect adrenaline to be released, and adrenaline actually causes relaxation. It has a sympathetic response. So yeah, again, I think we'll need to find out more. We need to. That question has come up a lot. I think I'll try to look for how to answer it, and then maybe probably in the next lecture I can talk about it. I'll look into it because that's one of the questions I've had every time I present this this lecture. Okay, but it's actually a good question. So I'll look into it, and then I will possibly try to give you an answer in the next lecture we have. Okay. So let's talk about the drugs. Now, we are going to begin with the sympathetic. We're going to begin with the sympathetic nervous system. So the adrenergic, when we talk about the adrenergic drugs, we're going to talk about 4 main receptors: the alpha-1 receptor, alpha-2 receptor, beta-1 and beta-2 receptor. Okay, these are very important receptors, and they do very many things, but I'm going to tell you what is the most important that you need to know. Okay, of course, the alpha-1 receptors, they are GQ coupled receptors. Those are stimulatory receptors which when they're activated, they cause phospholipase. There's release of phosphor. All these receptors are G coupled receptors. Okay, alpha-1 are GQ receptors, beta-1 and beta-2 are GS receptors, and then alpha-2 is a GI receptor, which means it's inhibitory. Okay, so the end result for alpha-1 receptor would be to increase norepinephrine release. Okay. Now, when you should notice that alpha-1 and alpha-2 receptors have a different response in terms of they have a different response in terms of stimulation. Okay, when you stimulate the alpha-1 receptor, you cause activation. When you stimulate the alpha-2 receptor, you cause inhibition. Okay, beta-1 and beta-2 receptors, when you stimulate them, you cause stimulation. Okay, so the way to think about it is that both alpha-1, beta-1 and beta-2, they cause stimulation. Alpha-2 cause inhibition. Now, there are so many things that the alpha-1 receptors cause, but the most important that I would say is for you to know that the alpha-1 receptor, when you stimulate it, it will cause vasoconstriction. This is the most important part that you need to remember. Alpha-2 receptors have 3 main effects. sedation, analgesia, and blood pressure. I will talk about it when I'm just going to talk about it briefly. Beta 1 receptor, you think about the inotropic effect and chronotropic, okay? So you think about its ability to, its contractility ability, and then also its ability to increase the heart rate. So beta 1 is a very important receptor for the heart. Beta 2, instead of cramming a bunch of things, the most thing that you should know is about its ability to cause bronchodilation. I think that will be the one that will be having the most clinical application, okay? Now, the sympathomimetics, these ones, they work by stimulating the alpha and beta receptors, okay? So I'm going to talk about the drugs. Remember, the alpha-1 receptor, the end result is to increase norepinephrine. Alpha-2 receptor, the end result is to decrease norepinephrine release. So the other one, alpha-1 is inhibitor, when you stimulate it, it's a G-coupled receptor, but it has, when you stimulate it, you increase activity, but alpha-2 is inhibitory, okay? So the first drug that we would want to talk about is the alpha-1 receptor antagonist, ephedrine, okay? And this is a common drug, even in practice of anesthesia. You'll see it a lot being used in your life as a doctor. Okay, and if you go into anesthesia, then this will be an everyday drug. It will be like Panadol. This is now ephedrine works on alpha-1 receptor predominantly. Okay, but it does not work directly. Okay, it's indirect acting. When we say indirect acting, it means that it is using someone else to act. So what ephedrine does, it goes into the presynaptic, and then naphthalene, and then it goes to norepinephrine, displaces it, so norepinephrine is released. Remember, norepinephrine works predominantly on alpha-1, alpha-2, and beta-1 receptor, but it works on alpha-1 receptor predominantly more than alpha-2, more than beta-1, okay? Adrenaline, which is also derived from norepinephrine. Remember, when I was talking about physiology, I said that norepinephrine is released from the adrenal medulla, but it's released in many places. But with the help of cortisol, cortisol is a drug that is used to transform. With the help of cortisol, it's transformed from norepinephrine to epinephrine. Epinephrine works on alpha-1, alpha-2, beta-1, and beta-2 receptors. So it works on all the adrenergic receptors. Norepinephrine works on all the adrenergic receptors except beta-2, okay? And this is very important when you're thinking about the treatment also. I think I'll mention it in the later slides. So if it's taken up, now the thing is, it is causing norepinephrine to be released, okay? And it gives those alpha-1 receptor stimulation. So when it gives those alpha-1 receptor stimulation, the end result is that you have a vasoconstriction, because alpha-1, I said, when you talk about alpha-1, when you stimulate it, you think about vasoconstriction, okay? And remember, when you have vasoconstriction, you increase the peripheral resistance, okay? The systemic vascular resistance is increased. And remember from your physiology that blood pressure is influenced by the cardiac output and the systemic vascular resistance. The cardiac output consists of the stroke volume and the heart rate, okay? So now what is happening now is that the sympathetic system, the alpha-1 receptor is being stimulated, you're getting vasoconstriction. The end result is increase in the heart rate, okay? Now, also, I beg your pardon, the end result is increase in the blood pressure, Okay, but because it also works on beta-1 receptor. Remember I said beta-1 receptor have inotropic and chronotropic effect, so it can increase the stroke volume, it can increase the heart rate. Okay, so it has one challenge. The challenge it has is that it has tachyphylaxis. As you could remember from your pharmacology, tachyphylaxis, whenever you use a drug for some time, it reaches a point where it stops working because in this case, you have used up all the norepinephrine resources, okay, that you have in the body. So, so what do you need? What do you need to know about ephedrine? It's indirectly acting, okay. It causes increase in blood pressure and heart rate, and then it has an effect of tachyphylaxis. It's the common drug that we use, especially when someone has had spinal anesthesia. They usually get hypotensive, okay? This is the drug of choice that we use to increase the heart rate, okay? Sorry, that we use to increase the blood pressure in hypotension, especially under spinal. So it's a very, very useful drug that we've been using in our setting. Let's see. So phenylephrine is now for it works directly on the alpha-1 receptor. So when it works on alpha-1 receptor, it causes vasoconstriction, and also the effect is increasing blood pressure. Now, there's one problem. It does not work on beta-1 receptor. So when you have vasoconstriction, the end result is that there is less stimulation of your baroreceptors. So when there is less stimulation of your baroreceptors, the body thinks, so when there is vasoconstriction and increase in blood pressure, the end result, the body responds using baroreceptors to cause bradycardia. So the effect is because it has no effect on beta-1 receptor. So what happens is that the vasoconstriction stimulates the baroreceptor, and then you get a bradycardia. So when you give a patient phenylephrine, they will get vasoconstriction. They will have a high blood pressure, but they will have a bradycardia. Okay, it has many clinical application. Like I think some people use it to cause vasoconstriction in the nostril before surgery. Well, in our setting, we're using adrenaline, but phenylephrine can also be used for that application. Okay, and if you give very high doses, especially even if it is topical, you can cause cardiac arrest because of the bradycardia it's causing. Baroreceptor stimulation. Okay, this one is not important. So these alpha-2 receptors also, I talked about them. You remember I said that they have inhibitory effects, okay? They are G inhibitory receptors, which means that they cause reduced, it reduces CAMP, okay? If I talk about now, adrenaline, the dosage matters, okay? When you have it at low doses, it usually predominantly works on beta receptors. And when you have it in higher doses, then it works on alpha receptors. That's why when you're going through anesthesia, you'll find us giving a specific dose of adrenaline to give a patient if he has a cardiac arrest. They will tell you a specific dose, because that's a specific dose whereby you have action on alpha receptors, because what you want to do is try to increase blood pressure if someone has had a cardiac arrest, okay? Another, we usually give them adrenaline of 1 milligram, okay? 1 milligram, that's another dose that the standard dose that is used during cardiopulmonary resuscitation, because at a different dose, it works at a different, it has different receptors, adrenergic receptors predominate at a specific dose. For beta-2 effects, we will see that we actually sometimes use adrenaline for asthmatics. It's because of its beta-2 effects. I remember I told you that beta-2 adrenergic receptors predominantly work on the bronchioles. Okay, So it can cause bronchodilation. Stimulating of beta 2 receptor, you get bronchodilation. We can also use it to increase heart rate. So it's also something that you should note. We can also use it in anaphylaxis at a specific dose. We use about 0.5 milligrams in anaphylaxis because in anaphylaxis, it's able to cause bronchodilation. It's able to increase the blood pressure during an anaphylactic reaction. Actually, adrenaline is a drug of choice that we use in anaphylactic shock. Okay, I've already said it works on both Norepinephrine, I've already said that it works on alpha-1 receptor. It still has some beta-1 receptor, but alpha-1 predominate more than beta-1. It's a drug of choice that now we're using for sepsis because of its ability to cause vasoconstriction. Remember, in septic shock, there is widespread vasodilatation of all the blood vessels. And this is why people get septic shock. It's the vasodilatation decreases the systemic vascular resistance, which is part of blood pressure. As I said, blood pressure is cardiac output times systemic vascular resistance. So when you reduce the systemic vascular resistance by vasodilatation, then you cause decrease in blood pressure. So in sepsis, we use norepinephrine because of its alpha-1 receptor effects of causing vasoconstriction. So it is the drug of choice to use in septic shock. Okay. So let's move. I think all of you are familiar with salbutamol. Okay. Salbutamol is a beta 2 receptor agonist. So it's able to work on the beta 2 receptor causing bronchodilation. Okay. You should never use it orally because the receptors are actually, the beta 2 receptors are in the bronchioles, so you can actually give it directly through inhalation. Giving it orally does not help, okay? And I've seen it being done a lot, but it does not help. It does not do much, okay? Dopamine has beta 1 receptor, so you expect it to have effect on the heart, okay? I want to talk about phosphodiesterase inhibitors. Aminophrin, but now aminophrin, because of its nanotherapeutic index, we're no longer using it a lot in clinical practice. So you can read about it, but we're not using it a lot for clinical practice. Now, phenoxybenzamine is also a drug. It's working. It's having an opposing effect on alpha-1 and alpha-2. It's an antagonist. The challenge is that it is reversible. Now, this is very useful to decrease blood pressure because by blocking alpha-1 receptor, you are causing vasodilatation. Alpha-1 stimulation causes vasoconstriction. When you block it, you have vasodilatation. So the end result is that you get a lot of you get decrease in blood pressure. So when you get decrease in blood pressure, you stimulate the baroreceptor, and the end result is you get a compensatory tachycardia. Okay, and this compensatory tachycardia we often we reverse it by using something that works on the beta receptor, because we said beta 1 receptor is predominantly a receptor for the heart, inotropic and chronotropic effects, or would say effects on contractility and heart rate. Okay. Phentolamine is also similar to phenoxybenzamine, but the only difference is that it is reversible. We usually use it in patients who have pheochromocytoma. Pheochromocytoma is a tumor of the adrenomedulla. We remember the adrenomedulla is the one that is producing norepinephrine and epinephrine. So when it's a tumor, it's producing very high amounts of norepinephrine and epinephrine. So you need to use a very strong drug to reverse these effects before you remove that tumor. So phenoxybenzamine is a drug to use. Okay, we usually use it in pheochromocytoma. It's already in your notes. Prazosin, we don't use it a lot in anesthesia, so I will not talk about it. Beta blockers, okay? Beta blockers, as you know, they are two classes. There are the ones which are non-selective, and then we have the ones which are selective, okay? And then we have, in the selective ones, we have the ones which are alpha blockers and the ones which are not alpha blockers. Now, concerning anesthesia, let me just mention about beta blockers, generally as a doctor and also plus anesthesia when you need it. Okay. Now you've often heard that this beta blocker is beta selective. This beta blocker is not beta selective. Okay. Now there are many different drugs, but a quick way to anticipate which one is beta selective and which one is not beta selective is to use the number. Okay. So I mean is use the alphabetical order. We usually say the ones that are from A to M are they are beta selective. Okay, they are beta 1 selective, so they predominantly work on beta 1 receptors. Okay, those are the selective ones. So we're talking about atenolol, bisoprolol, up to metoprolol. Okay, all those ones, they are beta selective. Okay, then others, including propranolol, are non-selective. When we say non-selective, is that they're working on both beta 1 and beta 2 receptor. So beta 1 is good because when you block the beta 1, you can cause you can decrease the contractility and you decrease the heart rate. So they are good in terms of decreasing that. So the effect of decreasing the heart rate, as I already said, it has effect on blood pressure because blood pressure is cardiac output times systemic vascular resistance. Cardiac output is stroke volume, which is correlating to the contractility and the heart rate. Okay, so you can decrease the blood pressure using the beta blockers. Okay, so but when they're working on both beta 1 and beta 2 receptor, so when you block beta 2 receptor, you cause vasoconstrict, you cause bronchoconstriction, which is not good if a patient has asthmatic, is an asthmatic. So I would say that the beta non-selective should not be used in asthmatic patients to decrease blood pressure. Okay, and also because of there are beta 2 effects, because maybe I didn't mention it, but beta 2 effect also has an effect on glucose metabolism. Okay, because it increases glucose metabolism. When you inhibit it, you inhibit glucose metabolism, so you can block the sympathetic signs of hypoglycemia, whereby someone is shaking, showing symptoms of hypoglycemia, like in a diabetic. So diabetics, I would say, don't give them the non-selective beta blockers. Okay. Then when we talk about the selective ones, okay. Now in the selective ones, we have the ones which are called alpha beta blockers. Now the alpha beta blockers are better at decreasing blood pressure. Okay, so the drugs from the atenolol, bisoprolol, up to metoprolol, A to M, those are beta selective. So they're working on beta 1 receptor and they're decreasing the heart rate and contractility. They have effect on the blood pressure. Now, there are some drugs that have also alpha 1 blockage. They block both alpha 1 and then beta 1 in these beta blockers. And these ones, you will see them being prescribed by most physicians as the beta blocker to treat hypertension, okay? Because they also block alpha 1, and so they block vasoconstriction. So they are better at decreasing the blood pressure. So an example of the two drugs are carvedilol and bisoprolol. So if you must have noticed them being prescribed, especially for treatment of blood pressure. They're the best because they also have alpha 1 antagonist effect and beta 1 antagonist effect without beta 2 receptor effects. Okay, so I would say when you become a physician, if you're going to prescribe a beta blocker, I think you're better off prescribing the one that has alpha 1 blockage and beta 1 blockage if you're using it for decreasing blood pressure. So I would say carvedilol is a very good drug, and bisoprolol in terms of decreasing blood pressure. And these are oral drugs, okay? So I think I've talked about that. And that's all you need to know about beta blockers. With one exception, Esmeral. Esmeral is also a good drug because we use it in anesthesia for because it's short acting. Okay. So if you want to decrease someone's blood pressure, if you want to decrease someone's heart rate for a very short time, especially like in intubation, because most of the time when we're intubating, the patients get what you call a hypertensive response to the intubation. So especially for high-risk patients, like elderly patients who are at risk of, if they get a high, if they get a tachycardia, they can get an MI, they can get a supraventricular tachycardia. You can give them a dose of Esmeral just at intubation. And it's important because it's short-acting, it works up to 6 to 10 minutes and then it's off. And this is because it has it's metabolized by esterases, so it has a very short half-life. It's the one that it's a very important drug. Okay, Sotorol is a class 3 antiarrhythmic. I would say I don't need to know much about it, but maybe a class 3 drug that you need to know is amiodarone. But you will talk about it when you talk about CPR. I think another class that we talk about will be lidocaine, which is a class 1B. That one you talk about it in local anesthesia because it also can be used as an antiarrhythmic. But concerning this, I think class 3 you would need to know amiodarone, and of course its effect of causing those hard depointes. But this one you talk about it when you talk about CPR. Okay. Labetalol, I think you read about it. So now we talk about the pharmacology of the parasympathetic nervous system. So we can talk about muscarinic receptors. Okay, so we have the ones that antagonize muscarinic receptors and the ones that block the muscarinic receptors. Now, remember I said that muscarinic receptors are found on the postganglionic receptor in the parasympathetic stimulation, and we said that the neurotransmitter that is released is what? The neurotransmitter that is released is acetylcholine. Okay, so you can play around with the levels of acetylcholine to influence the parasympathetic nervous system. When you increase the levels of parasympathetic, increase the levels of acetylcholine, you stimulate the parasympathetic nervous system. When you block the levels of acetylcholine, you inhibit the parasympathetic system. Okay, muscarinic agonists. I would say there are two muscarinic receptor agonists that you need to know. Okay, now muscarinic receptor agonists, these ones are stimulating the muscarinic receptor, increasing acetylcholine release in the postganglionic sympathetic system, and causing exaggerated parasympathetic effects. So there are two types. There are the ones which are direct acting, or can I say that the ones that are reversible, and then there are the ones that are irreversible. Okay. Now, the ones that you need to know are the irreversible ones are organophosphate poisons. So I think you will talk about them. I don't know which lecture. I'm not sure. Maybe I'm just going to mention them. And then you have the reversible ones, which we use in clinical practice. I think you will talk about them when you talk about muscle relaxants. Okay. Now, so they are all anticholinesterase, because remember when acetylcholine is released in the synaptic cleft and it goes on the acetylcholine receptor, stimulates it, and then it's broken down by acetylcholinesterase and recycled back into the preganglionic, in the preganglionic. So what these ones do, they inhibit the acetylcholinesterase enzyme. So acetylcholine is not broken down on the postsynaptic acetylcholine receptor. So it accumulates and causes exaggerated parasympathetic response. Okay. We have one of the drugs that we have is neostigmine, which you see when we'll be using, it will be used in reversing the effects of muscarinic, the effects of muscle relaxants. And this one, they will talk about it when you talk about muscle relaxants. Okay. So all these ones are in that class. Then we have also organophosphate poisons, which are reversible because they get the acetylcholine esterase and destroy it. And then you have exaggerated acetylcholine post-synaptic acetylcholine receptor stimulation, excessive parasympathetic response. That's why you see people with organophosphate poisoning, they will have parasympathetic effects. Okay, there's a mnemonic that people use to remember called dumbbell. But the best way is to think about it. They're having parasympathetic effects, so they're having rest and digest effects. So they are leaky everywhere. They have increased salivation, increased secretion, diarrhea, can pass urine. Then also, of course, constriction, pupil constriction. Okay, so you can think about it using a mnemonic or just thinking that they are leaky, and then they also have rest and digest symptoms. Okay, then lastly, I think the lecture has gone long enough. We're almost 1 hour. So in the next 2 minutes, I want to talk about muscarinic antagonists. Muscarinic antagonists are very important, okay? There are so many that you need to know that are in this group, but you only need to know 4 of them, okay? The 4 that you need to know are atropine, which you'll see being used a lot in practice. When you're practicing as a doctor, glycopyrrolate and hyoscine. So, and then ipratropium, okay? Now, atropine is, I know people like using atropine, but atropine has its issues, okay? Atropine is lipid soluble. So because atropine is lipid soluble, what it does is that it's able to penetrate the blood-brain barrier. So when it penetrates the blood-brain barrier, it is able to, it can cause effects of the CNS. If you've noticed, people who have had organophosphate poisoning, we usually treat them with atropine and we give them a lot of atropine. And you may have noticed that most of the time, when they recover, they have some CNS effects, okay? Remember, atropine is a muscarinic antagonist, so it will block the acetylcholine receptors, okay? So the muscarinic receptors, the postganglionic muscarinic receptors, so acetylcholine will not, so once it blocks it, then you will not get a lot of stimulation of the parasympathetic, which is very useful in terms of counteracting the effects of organophosphate poisons. Now, glycopyrrolate is actually very good because it is water soluble, does not cross the blood-brain barrier. So it's a very good drug. Now, what are they going to ask you about atropine? What you need to know is that it is lipid soluble. It's a very good drug for increasing the heart rate. Okay. Now, sometimes glycopyrrolate is also asked. Okay. Believe me or not, glycopyrrolate is available in our setting, and we use it much as it's not readily available in many places, but at least we have it. So now they're going to ask you a question whereby they're going to put for you atropine, glycopyrrolate, hyoscine, ipratropium, and they're going to ask you which one is the best for increasing the heart rate. Okay, so if they ask you which one is the best for increasing heart rate, atropine will be the answer. Okay, because they're all in the same group, but the best way to remember atropine is the best for increasing the heart rate. Okay, but sometimes they may ask you which one is the best for decreasing secretions, or they may put which one is the best anti-CLOC or decreasing secretion. It's the same thing. Glycopyrrolate is the drug of choice because it has no CNS effects. It's water soluble, so it's one that is preferred to decrease secretions. If they ask you which one is the best antiemetic in the muscarinic antagonists, it will be hyoscine. Okay. If they ask you which one is the best muscarinic antagonist in terms of causing bronchodilation, like in an asthmatic, it will be ipratropium. I think if you know that, then I think you'll be able to get all the answers of the questions I'm going to ask you on your test. Okay. I think I've ended here. Do you have any questions?
Yes, Doctor.
Doctor,
Yes.
Members, let us raise our hands and then we should be organized in asking the question. So, Kakoza, you go first.
beg your pardon on hyoscine and ipracopium, what they are based at.
Hyoscine and